gives me great pleasure today to welcome to the BMPA Professor Michael Benros, who is an internationally award-winning researcher. He's based at the Biological and Precision Psychiatry Unit in the Copenhagen, and he's going to talk to us about the epidemiology of infectious diseases as risk factors for psychiatric disorders. So welcome and thank you. You're going to finally answer Tim Crow's question for me.
Thank you very much. Yeah, and thank you for the kind introduction and the invitation to come here and speak. And I can say also agree that now there's more than 2 years since the pandemic, so we also need to take a step back also regarding long COVID and also look back at what we know from beforehand. And maybe one of the things that we can primarily now learn from COVID is more in general on how does the immune system actually affect the brain and how can it give no psychiatric symptoms, and for these persons that have them for a longer while, what is actually happening in the brain. So use this research-wise to gain new knowledge. But I will also speak a little bit about COVID-19, but the rest of the talk will be about infections in general and psychiatric disorders. Oh, yeah. But overall, in the beginning of the pandemic, we were very worried about this, that SARS-CoV-2 had a neurotropic potential that could enter the brain, and if this would occur in many of the subjects, it was cause severe deterioration of the mental health. But actually now, it has come down here. It is very, very rare, and it has only been shown worldwide in case reports in humans that it has been found active in the CSF, whereas the evidence is primarily from animal studies. So, but the larger studies on CSF, including our own CSF analyses, have not detected any PCR SARS-CoV-2 in the cerebrospinal fluid of the patients. But some of the patients have antibodies against SARS-CoV-2, and then the question is whether they come from the periphery or if it's actually intrathecal production. But in very few of these patients, it would likely be intrathecal production, as it correlates with the permeability of the blood-brain barrier and the level of inflammation in the peripheral blood. So therefore, it's actually more likely that it comes from the blood into the brain. But it can occur, but very rare. But also the post-infectious autoimmune encephalitis can also occur, as it can in response to other infections. But most commonly, it is this peripheral inflammation, and the more inflammation you have, the more likely it is to actually reach the brain and can give no psychiatric symptoms. And it's also something you can see if you just have a milder influenza. You can feel more tired than normal, you can have disturbed sleep, you can be more irritable, and all these symptoms are called sickness symptoms, and they will disappear once the infection have cleared. And that is actually due to the immune system's communication with the brain. And in animal studies, these symptoms, called sickness symptoms, can also be blocked with cytokines inhibitors. And they can be induced by many different infections and autoimmune diseases and etc. But also another thing we need to remember is this critical illness. So if many of the studies on COVID has been done on patients that are hospitalized. So if you are hospitalized, many other things actually happens to the brain. You can have electrolyte derangements that can cause delirium. You can have blood clots in the brain that can also give psychiatric symptoms. You can have lack of oxygen during hospital admissions, which can also affect brain function. So there's a lot of things that can affect the brain in these individuals. But when the pandemic first started, we also did a clinical study where we screened all patients daily that were admitted with COVID-19 to the major hospital in Copenhagen. And after finishing this first study only on patients, we saw that the most prevalent no psychiatric symptoms was delirium, which occurred in 34% of the patients. And if you were in ICU, it was more than half of the patients that experienced delirium. But then when looking at these numbers, this would be exactly the same for all the other patients in the hospitals. Because if you screen as a general medical hospital, 1/3 of the patient would have delirium at some point. And it actually looks very similar to this. So it's of course very severe, and delirium has been shown previously also in very large studies published in New England journals before the pandemic that can affect cognitive ability over time and also increase the risk of psychiatric symptoms on the long term. So, but we realized that we needed a control group. So that's where the whole field is going now, that we need control groups and match controls to the patients, like in all other research fields. Yeah. But then when just looking at the patients when they were discharged from hospitals, we did a MOCA cognitive test on the patients where they scored above 19. And then at a half-year follow-up, the cognitive functioning improved to almost 27. So you can see they are actually severely cognitive affected when they are discharged, but there's a very large and significant improvement when you compare to 1.5 year after. But if you look in a control group of matched patients, so here we see the 1.5 year after, where all the patients were screened once again, you see the cognitive test was 27, and it is significantly lower than the matched control group, but in absolute numbers, the differences are very small, and much smaller than we would have thought before. Even though we could, if we take more severe cutoffs, they seem to be more affected than the controls. And it's also important to say here that both groups were severely ill patients, and the controls were also matched on CRP levels, and they were all, at some point during admissions, had CRP levels above 200 in both groups. So they had severe inflammation. And then if we continue to look at psychiatric symptoms, you see they actually are very similar, that for people fulfilling a psychiatric diagnosis a half year after was 19% in the COVID-19 group and 20% among the matched controls, which is an elevated risk. In the general population. It would be around 10% in Denmark at least, but compared to the matched controls, it's actually very similar. So both groups are affected both cognitively and also regarding psychiatric disorders. And if we only look at symptoms, it also looks very similar, and the primary one that was statistically significant between the matched controls was an altered smell that occurred more frequently amongst the COVID-19 patients. And then we did some meta-analyses during the pandemic to see if having a mental disorder was associated with increased risk of being hospitalized for COVID-19 infection. So it's actually the other way around, but in a health perspective. And here we can see that patients with severe mental disorders have an increased risk of being hospitalized for COVID-19. These are the unadjusted numbers, and here are the adjusted for comorbidities, where they actually have 77% increased risk of being hospitalized for COVID-19. And then when looking at the risk of dying of COVID-19, we see that people with the severest mental disorders also have an increased risk of dying when acquiring COVID-19 compared to controls, and particularly for people with psychotic disorders, where they have a 70% increased risk of dying due to COVID-19. So this also led to our advocacy in our European associations for vaccinations for people with mental disorders. So this is, of course, now published a long time ago, but at that point, people with severe mental disorders were not prioritized in the same way with people with other general medical conditions. But as you can maybe see here in the numbers, many of the other general medical conditions actually have about the same elevated risk of being hospitalized for COVID-19 and also for COVID-19 mortality. But another thing I think is also interesting is that this is again not new. This was a Danish population-based study we did prior to the pandemic. And in Denmark we have very nice registers where we can follow the whole Danish population as one large cohort and see every time they come to the hospital, every time they have a prescription for some medicine, and we also have the biobanks. So we utilize that data, and there you can see that people with severe mental disorders also have an increased risk of dying for all other types of infections by 52%. So these numbers are actually very similar to what we see for COVID-19. and it of course depends on age. And also when taking the historical perspectives, as we heard about just before, with the Spanish influenza pandemic, but also others, it's actually not new, and all the way back in history there has been noted records of people being severely ill and then with infections and experiencing psychotic-like symptoms. And you can of course argue that that was actually delirium they had. But also Kraepelin, he proposed that schizophrenia might actually be an immunological disease. And that was because at that point he noticed that some of his patients had different skin lesions, but they didn't know what it was until the syphilis was identified in 1905. But at that point there was no treatment for syphilis. So actually the first Nobel Prize for psychiatrist was given to Vagner Jarvik for his malaria treatment, where he induced malaria into the patients, which activated the immune response, and then in some cases fight off the syphilis infection and cured the patients. But for other patients, it was not that good a treatment, because it could also be dangerous. So, but when the antibiotic was invented during the Second World War, and after that spread out to the general population, many of these patients admitted to the psychiatric wards were cured or went out of the wards. And at least in Denmark, it's estimated that it was 1/3 of all patients admitted to the mental health state wards that had neurosyphilis. So it was actually a major breakthrough, and at the same time point, the current antipsychotic and antidepressants, more or less, were invented. And then the research into infections and mental health actually waned a bit, since it was believed that it was only due to syphilis or maybe the influenza pandemic, but it was thought that the brain was completely protected by the blood-brain barrier, and it was thought that there was no immune cells in the brain. But in the late 80s and beginning 90s, it was discovered that this blood-brain barrier could actually be more permeable during infections, inflammation, and head trauma. And later on, it was also discovered that we actually have immune cells within the brain, which is the microglia that can be activated. And later on, we also discovered that there is actually a continuous communication between peripheral immune cells and the brain. And just a couple of years ago, it was discovered that there's actually also a lymphatic system within the brain, like in the rest of the body. So regarding this knowledge between the immune system and the brain, we have gained a lot of knowledge within the last decades. And relevant for psychiatry, some of the first genetics studies, large scales, also showed large associations within the HLA region, which is primarily the region governing immune cell responses. And several of these epidemiological studies, which I will come into later, and also the discovery of NMDA encephalitis have triggered the interest into this field. And lately, of course, the COVID-19 pandemic have made it so everyone have heard about this association. So when looking to the Danish register studies, and these are conducted prior to the COVID-19 pandemic, so it's infections in general. So for this study, we have a cohort of about 3.5 million individuals. And here we can see that each number of severe infections that require hospital contacts increases the risk of a psychotic disorder in a dose-response relationship. And the last blue column is if you have an autoimmune disease and 3 and more infections, then you have almost 3.5 times increased risk of getting a new onset psychotic disorder. And these numbers are of course adjusted for social factors and a family history of mental disorders, and etc. And when looking at the type of infection, it was bacterial infections that are associated with the highest risk. And this could make sense, since the bacterial infections are more likely to induce the highest immune response. And this was, of course, also what's different from COVID-19 compared to current influenza, that it was a new infection. So that's why we had this cytokine storm, where they induced a very large immune response, and much larger than is normal for virus infections. And therefore, it was also more likely to actually affect the brain than influenza infections. And then when looking at mood disorders, we see the same pattern, that each number of severe infections actually increased the risk in a dose-response relationship. And actually, if you, instead of this, only look at if you have 5 or more different types of infections, then your risk of a new onset mood disorders is actually increased by 5 times. But then we also wondered whether this was only associated with very severe infections, or whether the less severe infections treated at the general practitioner were also associated with a higher risk. And of course, these numbers are not completely comparable with the other ones, as here the comparison population is much more healthy. It's people that have never been prescribed antibiotics or anti-infective agents by the general practitioner. But here you can see that also infections treated by the general practitioner increases the risk by 37% of psychotic disorder and by 64% for affective disorder. And then if the infection is severe enough to require hospital contacts, then the risk is increased by 2 times for psychotic disorders and by 2.59 times for mood disorders. So the severity of the infection clearly matters. And then we're looking at whether it required, which type of treatment it required. The highest risk was observed, it was a severe infection requiring broad-spectrum antibiotic treatment. Whereas if it were antiviral treatments, there was actually not conferred with an increased risk. So that also indicates that it was not only going to the doctor that was associated with this increased risk, but the severity of the infection. And also for these milder types of infection, we can see a dose-response relationship. And of course, here it comes up to many infections. So if you have 20 or more infections, you have a highly increased risk for mood disorders. And you can actually see that it differs, that the red ones are for mood disorders, which are associated with higher risk than psychotic disorders. But then when we look at it epidemiologically and broaden it out to all the psychiatric categories, we actually find the increased risk across many of them. Of course, they are different, but so they seem to lack a specificity. So there's like a overall increased risk. So you can both say that, argue that specificity is needed. You could also say that the infections do not respect the boundaries of ICD-10, but at least there's many overall associations. And this also goes for suicide. So the more severe the infections are, and the longer days it had required you were admitted to the hospital, the higher are the risk for dying of suicide subsequently. And all these risks are temporally associated, so the risks are highest just after you have the infection. And then we're looking at infections inside of the brain, CNS infections. They're associated with a 40% increased risk, and this is any mental disorders. And then we're looking where it is in the brain. The risk is highest if the infection is inside the brain, encephalitis. And for the brain, it was actually the viral CNS infections that were associated with the highest risk. And you could say that maybe they are present for a longer time in the brain before actually being treated, but basically we do not know. And we're looking at the mental disorders that are the highest risk after CNS infections. It is particularly the organic mental disorders, which is also the correct diagnosis if you think it's the CNS infection that has caused the psychiatric symptoms, but also intellectual disability and a smaller risk for many of the other ones. But for infections in the brain, you see a very clear temporal association. So the first half year after you have had an infection in your brain, you actually have a 27 times increased risk of a new onset mental disorders. So this is a very large risk increase in epidemiological studies and all studies, I think. And the risk actually remains significant up to 20 years after. It just looks very small compared to the initial high risk. And this is a study we did on IQ data, where when people go to conscription day in Denmark, they also have an IQ test conducted. So So here we had the IQ data from 161,000 individuals, and we looked at the number of prior severe infections, and we could see that the number of severe infections was associated with a decline in the IQ score by up to 9 points if you had 5 or more severe infections requiring hospital contacts. So there seemed to be association with cognition, as has also been discussed much with COVID-19, and you can also see after people are admitted at the hospital, and particularly if they have delirium, you can also see declines like that afterwards. And then we're looking at the genetic component. We looked here, this is a schizophrenia sample where we also had genetics, and we made it into 4 quartiles based on the polygenic risk score for schizophrenia. And the blue ones are only the genetics, so this is based on a blood test when the child is born. Only on the genetics, if you're in the 4th quartile, you can see that this child will have a 2.3 times increased risk of developing schizophrenia when they grow up. And then the red one is if they also had an infection, then they had a 3.5 times increased risk of developing schizophrenia. But there were no interaction between these two, so there were additive risk factors. And then we did a GWAS of infections of 65,000 individuals. And here we show, and this is not surprising, that infections transmit from a person to a person. So the genetic contribution to acquiring an infection is very small, and the SNP heritability was only 4%. So the genetic part only explained 4% of getting an infection. But of that small genetic part, there was actually a moderate overlap with the genetics for mental disorders. So there is a small genetic component to this. And this is the polygenic risk score we made for acquiring infections. And then we're looking when people are first diagnosed with a severe mental disorder, so the first blood test they had at the hospital, the average CRP level are increased, and it is 3.5 in average if you have bipolar disorder, and 3.9 if you are admitted during manic states. Whereas in healthy individuals, the CRPs would be below 1. And these elevated CRP levels actually concur. The higher CRP levels you have when you are first admitted, the higher your subsequent mortality. So it's something we need to use clinically also to actually investigate our patients sufficiently to investigate which somatic disease they actually have. And then we did a meta-analysis of all CSF studies throughout time, and the current evidence is that they show that there's an increased permeability on a group level of the blood-brain barrier, both for depression and schizophrenia, and there's elevated CSF cytokines, 2 at least, for psychosis. And now we are underway with our own clinical studies, which Rose is also doing. And then why is this also interesting in the context? So if this association between the immune system and the brain can actually be targeted with medicine, we can potentially improve the treatment we have today. So if immune modulating treatment can, for some patients, help, it would be fantastic. So that's why we have also done meta-analysis of all placebo-controlled randomized trials with immune modulating treatment, and this is for depression. And actually when combining them, there's 10,000 people that are included in these RCTs, but most only had the depressive symptoms, so it was like a secondary outcome of the trial, where the improvement was a standard mean difference of minus 0.41, and that is a moderate effect size, where the current antidepressants that has the highest effects of all of them have a standard mean difference of 0.42. And when only looking at the ones that have clinical depression, there was actually an improvement of minus 0.64, which is a moderate to large improvement of the depressive symptoms. And here we look at the different types of agents that were used, where the most promising were actually steroids, where we are now initiating a very large trial in Denmark to validate this, and also on biomarkers. And then we're looking at doing the same exercise for psychosis, and this has been done by Rose, who's here for a PhD student. And there we show that this is then a mean difference, so it's different than the standard mean difference. This is a mean difference on the PANSS score. And the overall effect is minus 4.57, which equals a small effect. But the ones that displayed the largest effects was NAC and no steroids. But here, for this meta-analysis on psychosis, it's important to note that the larger the studies were in the meta-analysis, the less were the effects. So it's not ready for clinical use yet, which also takes me to the take-home message that what we are lacking for this immune modulating part is very large, well-controlled, placebo-controlled RCTs based on immune markers, so we can identify subgroups of the patients that could benefit from these treatments. And also we need to have detailed immunologic characterizations from different tissue, from the cerebrospinal fluid, blood, and microbiome, which we are also doing currently to actually be able to stratify patients based on the stable biomarkers. And this could potentially pave the way for new treatments. But overall, to conclude, infection and autoimmune diseases are associated with increase of mental disorders in dose-response relationships, so it's not only confined to COVID-19. And at diagnosis, there's increased levels of peripheral inflammation and increased blood-brain barrier. And there is a potential for immunomodulating treatment for mental disorders, I believe. Thank you very much, and thank you.
Thank you for that. I took from that it's safe to get a cat, is that correct? I think we've got time for a couple of questions as we're going to coffee break afterwards. Yeah, Boyd?
Thank you, that was really interesting. I was going to ask about, do you have any data about the timing of the infection and the likelihood of getting psychosis? So is your risk, and you may have said that, but sorry if I missed it, but is your risk higher if you get the infection when you're in your teens and then you develop psychosis later, or?
Yeah, we have that both regarding age. Actually, there wasn't a large difference between if you got it as a child or a teenager. The largest temporal association was the closer to the infection, so the time after infections was the time at the highest risk of psychosis. That was like the clearest temporal associations. But I know there have been a lot of speculation about if you have a childhood infection, then the risk would be much higher. But actually on this nationwide data, it looks as about the same, whereas it's the temporal association to the infection that is the clearest association.
Thank you. Gentleman in the blue shirt.
Yeah, hi, thanks for that. Can you entirely rule out the behaviour of people who are going to later have mental illness? And we know about childhood behaviours of people who go into schizophrenia and so on, doesn't put them at increased risk of infections. So the cause and effect thing might start to break down a bit. But I mean, I suppose I think it's unlikely, but maybe it should be considered.
Yeah, and I definitely agree with you. And in these very large epidemiological studies, I mean, they show associations, not causal effects. So there will be a mixture. Even though we do what we can to control for socio-economic factors and family history and all these things, we cannot rule out that in some of the cases there will be some residual confounding. So likely it's a mixture of both, some causal effects and some where it's the other way around. And for that, so I mean, evidence-based, you base it on, if you have very strong associations like we show in the epidemiological, there's these Bradford-Hill criteria. If there's a dose-response associations, if there's temporal associations, if it can be reproduced in animal studies, if there's indications that are treatment effects from RCTs. So all these the field actually have, but the thing we are lacking is the specificity, that it seems to go across, and I think that's the big question. And of course, the field needs to know what is actually molecularly going on in the brain. And for that, if you can identify that, then the pharmaceutical industry can develop drug against it. But for now, we have this circumstantial evidence, but we need to know exactly what is going on.
Nick, quick one before break.
Yeah, thanks. I was interested in your slide on COVID-19 and delirium. Part of my clinical work is with patients with brain injury, and in 2020, we had a whole series of patients hospitalised with brain injury who got COVID and then developed the most spectacular deliriums that I think I've ever seen. Of course, when someone has neurological damage and they get an infection, they're more likely to get delirium, but not like this, and there was a whole series of them, and I've sort of searched in vain for an explanation of why that might have been. I know this might not be an answerable question, but I just wonder whether there is any even speculative explanation of why this was so severe in those patients.
Yeah, I mean, I think I would agree with what you said also, because if you have a prior CNS injury like a head trauma, or if you have a dementia, then you are much more likely to get delirium if you have an infection. And then the COVID came in as an infection the system wasn't used to, so they would respond more excessively, and these patients would be much more vulnerable to that. I think that would be my take on it. But of course, we would need, ideally, to have control groups also specific for that, to answer people with head trauma that have other infections that are just as severe, just as high as CRP levels, and then actually compare their symptoms. But I would think that it would be rather similar, actually.
That was precise and it was biological. Thank you very much, Professor Benros.